work that we presented at ACTRIMS, there we tried to check whether neurofilament light, and to be precise, serum or plasma neurofilament light is a marker of axonal damage or neuronal damage, whether it can provide any prognostic value regarding COVID-associated mortality or death. So when we started this work, before that, there were some papers which has shown that COVID-19 patients have elevated levels of neurofilament light. But the drawbacks with most of those studies, they were small cohort studies, the study which has used maximum patients was 142 patients, and they were just single cohort studies. So we thought we should expand on that. First, we tried to validate the findings from the previous studies, and then move on to see whether this neurofilament light measurement in COVID-19 patients can provide any prognostic value, which can be used by the physicians or doctors. And also another part that we tried to identify in that study, to find out the pathway by which COVID-19 is causing, if there is any neurodegeneration, the pathway by which COVID-19 caused the neurodegeneration. For this study, we have collaborated with Brescia Hospital in Italy. They have collected the patient samples and they have provided this patient serum and plasma samples, which we have used for this study. Also, I would like to acknowledge my lab colleague, Peter Kosa, who worked on this study with me to develop the models, predictive models. So in the first cohort, we had just 30 COVID patients, and all from different categories of disease severity. All 30 were hospitalized. And out of that 30, 10 were hospitalized in a general ward, which has moderate disease severity. 20 were hospitalized in ICU with severe disease. Out of the 20, 10 were discharged alive, or those who survived in the ICU, and 10 those who died in ICU. So we have different disease severity. And we have seen that these COVID-19 patients, they have elevated levels of neurofilament light in their serum or plasma compared to healthy controls. And the patients, those who have critical disease or severe disease, they have even more elevated levels of neurofilament light compared to patients with moderate disease severity. Then as we have validated the findings from previous studies, the next thing we try to identify in this hospitalized or in critical hospitalized patients, when COVID-19 gets, when neurofilament light in these COVID-19 patients get elevated. So for that, we have chose the second cohort. In that second cohort, we have just 20 patients, 20 critical COVID-19 patients hospitalized in ICU, and similar 10 died during the ICU in ICU, and 10 survived. But for these patients, now we have collected the 3 longitudinal samples. So one sample collected at the time of hospitalization, second sample around 10 to 15 days after hospitalization, and third samples around 25 to 30 days after hospitalization. And we have seen that both this survived as well as died patients, at the time of hospitalization, both have elevated levels of neurofilament light compared to the healthy controls. But when we compared between the survived and died patients at the time of hospitalization, or you can say day 0, they have similar level of neurofilament light, almost similar level of neurofilament light. But as time passes, day 15 and around day 25 to 30, only patients, those who died afterwards, they have significantly elevated levels of neurofilament light compared to the patients, those who survived. So it has shown that neurofilament light has some clinical value related to COVID-associated mortality or COVID-associated death. So once we did this, also in this cohort 2, we tried to identify how the other biomarkers, other biomarkers which I have previously identified as a markers of COVID-19 mortality, such as LDH, lactate dehydrogenase, C-reactive protein or CRP, or a total lymphocyte count. So which has been identified other groups as a markers of COVID-associated disease severity or mortality. And these are mainly the markers of organ damage. If any organ damage, lactate dehydrogenase is released, and it comes in the serum, and it can be measured as a marker of a critical organ damage. So in this cohort 2, we have seen that these other biomarkers, LDH, CRP, or lymphocyte count, they are more elevated at the time of hospitalization or when the patient is hospitalized in ICU, and particularly in the patients, those who died afterwards. But in the latter time points, like day 20 or day 30, this biomarkers comes down. So when we have tried to see the correlations between these biomarkers, so early time point for these biomarkers, like such as day 0, strongly correlated with neurofilament light at latter time points, like day 20 or day 30. So it indirectly says that the critical organ damage, like or other organ damages, like such as lungs or liver or other organs, damaging first, and then there is a CNS damage. So it may suggest that like this critical organ damage, critical other organ damages is causing secondary effects, that is CNS damage. So or we can say that like COVID-19 is not having direct effect on CNS. It may be the indirect effect because of the damage of other organs. So after this study, we move back to our cohort 1 and we try to develop the predictive model where we can see how neurofilament light can predict the disease model, like COVID-19 mortality. And we have developed the model in cohort 1, and we have seen that this neurofilament light can give additional predictive value on top of age and gender, which are like largely used epidemiological markers for COVID-19 associated mortality. And same model, like our predictive model that we have developed in cohort 1, we have validated in cohort 2. But again, the problem was like our cohort 1 and cohort 2 were like small cohort, like cohort 1 was of just 30 patients, cohort 2 was just of 20 patients. So we try to, like whenever you develop any predictive models, it's better to validate in different cohorts and try to use as many as possible patients. So in cohort 3, which is a kind of our strength, where we have almost 300 critical COVID-19 patients, those who were hospitalized to ICU, and almost 50% of those died during the hospitalization and 50% survived. And we try to use age and gender matched cohorts, age and gender matched patients in cohort 3. So whatever we'll see, there is a pure effect of neurofilament light rather than like age and gender in that. And we have validated our predictive model, which we have seen in cohort 1, in cohort 3, where we have seen neurofilament light provides additional predictive value on top of age and gender. But again, like when this like cohort 3 validated it, but in cohort 2, where we have longitudinal study, where we have seen this predictive model is validated only in the latter time points, like time point, like 20 days after hospitalization or 30 days after hospitalization, and not at the time of hospitalization. So it says that like neurofilament light comes as a biomarker for COVID-19 associated mortality, but in latter time points. And maybe these are time points which are very near to the death, and which may be too late for the doctors to identify it and to improve on the medical treatment for the patients. But when you study this neurofilament light in correlation with other biomarkers such as LDH, CRP, or lymphocyte count, it may help the doctors to identify the patients or COVID-19 patients at early, which are like highly vulnerable to COVID-19 associated death. And they can escalate the medical treatment for those patients and may survive the patient's life even before the patient's getting worse disease prognosis. So that was kind of our first, that's kind of our study regarding neurofilament light and how it can be used as a biomarker for COVID-19 associated mortality.